afternoon. Thank you so much for joining us again. We're thrilled to have you here. This is week 4 of our 5-week program. And as usual, we're going to start with our centering prayer. I do want to just remind everybody that today is going to probably run a little bit longer than we have in the past. So let's get started right away. Okay. Shall we pray? Heavenly Father, we come before you with the foreknowledge that the lives you have granted us lead us through death to your gift of eternal resurrected life. You have given us the commandment to love one another as you have loved us. Through this love, help us to fulfill our obligation to our families through prayerful dialogue and these preparations. Be present, Lord Jesus, as we contemplate our mortal nature with the assurance of your presence throughout our lives. Amen.
Amen.
All right. So again, Chaplain Deacon Paula Waite, staff chaplain at Beebe Hospital, and I'm joined by Dr. Sarah Matthews, our palliative care physician at Beebe.
Hi, everyone.
We have worked through quite a bit up to this date. You have some forms. I'm going to remind you about this. You have the Beebe Advanced Care Planning booklet. If you don't have one, you can pick one up from Father Jeff. You have the Beebe Advanced Healthcare Directive that, once you finish all of these weeks can be completed. And you have the very informative and helpful piece of end of life that St. Peter's has put together. So keep in mind that once you get through these classes, you're going to have that. I bring that up at this point because this will be the last week that Sarah and I are joining you. Next week, you will be joined at the same time, same place with the attorney Rebecca Doyle, who will be talking about making and conveying legal decisions, your assets, things like that are outside of the scope of healthcare.
Yep, we can try to give a lot of guidance on the medical and healthcare piece of it, but we do not know too much about the legal part.
No, absolutely not. So today we're going to move into a very broad topic area, which is settings of care. We're going to also talk about hospice and bereavement during this session. So I'm going to let Sarah get started because this is very technical. So if you'll get us launched and then I will follow through.
Absolutely. So as you can see on the slide, it's broken up into 2 different big categories, and that's what we're going to talk about today. So the acute illness is the list of different places you might go when you're sick. So something happens, you get a pneumonia, you fall and break your hip. These are some different places you might go on your journey with that acute or short-term illness.
Okay.
Yeah. The other half is long-term care. So these are options for the different places that someone might live, particularly if they're nearing the end of life.
Okay.
But the different options are for people that need different levels of support.
Okay.
Yeah. And we'll talk about what these different ones are, why you might choose some of these options or not choose them.
Perfect. And we're going to start, so we're going to unpack each of these. We're going to start with, by unpacking each of these, including acute illness. But first, we're going to talk about, you've been ill, you've come to the hospital, and the thing that everybody wants to do is go home. So the question is, what we have to look at is when you are discharged from the hospital due to an injury or new illness, you may or may not be able to go home. If it is something that requires the ability to take care of yourself and you are unable to do so for whatever reason, you may not be able to go back to your own residence. But if you have available help at home, whether it's home health, a spouse, children, something like that, and you might be able to go back even though you need help with things. Alternately, if it's a type of care that requires medical condition treatment with doctors and or nurses, then you may or may not be able to go home, right? And you're going to talk about that, right, Sarah?
Yep.
Okay.
A lot of it's going to depend on what kind of care you need when you're leaving the hospital.
Yep.
So some examples we'll get into more later are do you need antibiotics because you had a bad infection and you still need those IV antibiotics for a little longer? Or, you know, did you have a fracture of some kind and you need to do that physical therapy to make sure that you get all your mobility back?
Okay, so it could very well be a nursing care. It could be a physical action, whether it's, you know, I fractured my shoulder and I just need help with that. And occupational therapy, can you explain what that is?
Yeah. So occupational therapy helps people to do all the functions of their daily life. So physical therapy, you may be familiar with, would be things like walking, like moving your arms and legs. Occupational therapy helps with things like, well, are you able to lift the spoon with that bowl of cereal? Are you able to dress yourself? Okay. Can you get up and use the bathroom? So it's very functional.
Okay. All right. So that's if you can get home, and we're going to come back to that. But if we can't get you home, then we got to talk about some very specific things.
Yes.
And that's, I'm going to turn it back over to Dr. Matthews right here.
So the first one of those places you might need to go if you can't go home is a rehab facility. So this is a place for someone to go after an illness. And this would be if they need different kinds of therapy. So if they need physical therapy, occupational therapy, like we just talked about, also speech therapy. So they can help with a variety of things. Okay. Sometimes people have trouble swallowing after a severe illness, or especially after if they were intubated and had mechanical ventilation, like we talked about in previous sessions. Once that breathing tube comes out, it's really hard to swallow after that.
You bet it is.
Yeah, it takes a lot of therapy to train those muscles how to work again.
And it doesn't matter how old you are with something like that. We have a patient right now that is 50 something in the hospital, and unfortunately he had COVID and he had to be intubated. Well, we were able to get him off of the breathing tube, but unable to speak yet, and just learning to even take ice cubes. Right. So a lot of these things really have to be helped. You can't just go home and do these things.
Right, right. Yeah. So in an example like that, that person would definitely need to go to a rehab facility so they could get the speech therapy, the physical therapy, the occupational therapy.
Okay.
And then, so basically someone might stay at an inpatient rehab as long as they're continuing to progress with their therapy. So a lot of times we have families and patients that might expect they're going to go to rehab and get better than they were at baseline, better than they were at home before they even came to the hospital. And rehab can't do that. No. Yeah. Rehab is not, it's not magical. So basically someone would stay at rehab until, as long as they're improving with the physical therapy, pretty much getting back to their baseline.
Okay, because in the hospital, we do physical therapy and occupational therapy and speech therapy to determine all these things, but it's not as intense as you would have at rehab.
Yes.
They physically have to, if they leave us and go to a rehab facility, they have to be able to participate in significant amounts of time of that therapy. Yeah.
And so acute rehab is actually at least 3 hours a day of therapy. Okay. Yeah, so it's quite a bit. So this would have to be someone who's pretty functional, actually. Sometimes patients are too sick to even go to rehab because they might be too sick to be able to do 3 hours of therapy a day.
Would that, and what would happen with that? They stay longer with us?
Or they might go to one of the other locations we're going to talk about.
Okay, all right, good.
And the purpose of going to rehab, kind of like we talked about, is to help people function in their life again. We want to help people be as independent as possible. We want to help them interact with their family. Maybe they're still working, maybe they're not, but maybe they have recreations and hobbies they enjoy. Okay. Yeah, so we want to get people back to their life.
Fabulous.
Yeah. So, a perfect segue. So Chaplain Paula just asked about, what if someone can't do that intensive 3 hours a day of rehab?
Because that is a lot.
It is, especially for someone who might be frail or weak from their illness.
Well, again, using the example of the gentleman that's currently in the ICU, he's unable to lift his arms. He can't physically lift his arms. Now, I think that he's been in the hospital almost 3 weeks. Almost 3 weeks. and that people really get deconditioned after even 1 week in a hospital bed.
Yeah.
So anticipating, part of it is educating your family, or families need to understand this, that you may think, oh, well, he's just, you know, everything's fine now, but they're deconditioned.
Yep, yeah. But deconditioned, term we use in the medical field, and it just means that a big illness like this takes a lot out of someone, and it's really hard to regain that strength.
Gotcha.
Yeah. So the skilled nursing facility is a place for someone to go who does need nursing care, or they need rehabilitation services.
Okay.
Like we talked about the physical therapy, the occupational, the speech therapy, but for 1 hour per day as opposed to 3.
All right.
Yeah. So that patient is a perfect example. He probably can't do 3 hours of therapy, but he would benefit from going somewhere like this where he could participate in 1 hour as much as he can.
Okay. And you can graduate.
Yes.
Okay.
Yep. Right. You can graduate. Other reasons someone might need to go to a skilled nursing facility would be, again, if they need a nurse to be coming and doing IV medicines, like IV antibiotics.
Yep.
Or if they need very intensive wound care.
Okay.
And they have nurses and wound care specialists coming and doing dressing changes multiple times a day, things like that.
Because that's something that can't, number one, happen at home. And it's not going to happen in a rehab facility because they don't have that kind of staff, right? Okay.
Yeah. And we'll talk about this a little bit as we go on. Right now, we're talking about short-term skilled nursing facility.
Right.
That means right after you have this acute illness, and the goal is to get back to your home or back to your previous living situation.
Okay.
Later, we'll talk about sometimes people do live long-term at a skilled nursing facility.
Correct.
Yeah, but we'll talk about that later.
So you've got listed here, Sarah, the conditions that would require that. This is these are a lot of conditions. Yeah.
Yeah, it is very broad, and these are just examples. But some reasons would be a severe infection, which we call sepsis.
Okay.
It might be someone that has a joint replacement, if they have a heart failure, or even possibly a heart attack.
Okay.
Sometimes if they have kidney infections, urine infections, a severe COPD episode, and they need more medicines for a longer time. Okay. But just a variety of examples.
All right. And we're going to talk as we move forward, we'll talk about some examples of these places, but we're going to stay on the technical medical side right now. Okay.
All right. So another type of facility someone might go to when they're leaving the hospital from an acute illness is called long-term acute care, or Ltac. Okay.
And we do call it Ltac in the hospital, so we apologize, but that's what it is.
we have a lot of acronyms.
Yes, we do.
So this is really someone that needs a higher level of care than the skilled nursing facility.
Okay.
Essentially, they need to continue hospital level of care for a longer period of time.
Okay. And that's not, we can't do that
well, either we can't or they're stable but sick. Okay. So, we might know exactly what they need, but they're going to need it for a long time. Okay. And this long-term acute care would be the best place to get that treatment. Okay. All right. So this could be, like it said, someone with a chronic critical illness. So an example would be someone who's in the intensive care unit. Okay. For a long time. Let's say they were on the ventilator, the mechanical ventilation, for several weeks. Yep. They couldn't come off of the ventilator, so now they have a tracheostomy, which is a hole in the throat, and the breathing tube goes through the hole in the throat to keep them on the breathing machine long term. So their lungs can recover, hopefully. And hopefully, yeah. I mean, that's the goal. That's the goal. Yes. Yeah. Okay. So someone has a tracheostomy, a new tracheostomy. That's a very common reason to go to an Ltac after being in the hospital. Okay. Because they're going to need more intensive care for a longer period of time while they're working on that tracheostomy. And I will stop here and say, we can actually say that for those types of patients who have received a tracheotomy and have to continue to be on that breathing machine, there are only 2 locations in Delaware
well,
Close
to Delaware, close to Delaware for that treatment to continue.
Yeah.
One is up in Wilmington, and it's called Select.
Yeah.
Select Specialty,
Mm-hmm.
yes, Select Specialty, and they have the capacity and the rooms in order to care for that patient.
Yes.
The other Ltac that we have near us is in Berlin, Maryland.
Yes, exactly.
And so it's when you have a patient, when you have a family member who has this type of condition, and we know we can't get that tracheotomy, repaired in swift order, this is guaranteed. You're not going to have it here or in Dover or anywhere else. You're going to actually have to travel.
Yes.
And I'm going to use an example. We had a patient that had, at the beginning of COVID, was very long-term on the ventilator. He did survive and is doing quite well, I might add, but he had a tracheotomy. Well, he had to go to Berlin, and that was closer for their family to be able to know where he was, even though there wasn't visitation at that time. But he recovered from that. Yeah. It doesn't automatically guarantee that they can get out and recover, but it gives them the therapy required in order to try and get them there.
Yep, exactly. So like Chaplain Paula was saying, the hope is always to recover from this prolonged critical illness. Sometimes people who go to Ltac may still pass away from their illness because you're very sick if you're going to an Ltac.
Yes.
Yeah.
Okay. So we've taken a look now at acute illness, starting in a hospital setting generally, the desire to go home. There could be a rehab facility. It could be a SNF. And that's our acronym again.
For skilled nursing facility.
For skilled nursing facility. And then we have the Ltac, which is a long-term acute care. But we know in the hospital, as healthcare providers, we know most people want to go home. If there is any way they can get home, that is what they want to do. And the first thing we look at in the hospital before discharge is safety. Can we safely discharge this patient to their home? Do they have the ability to care for self, and or do they have people that will be able to care for them? So one of the things that we look at is what is the level of care that is needed. Now that is registered on something called Activities of Daily Living, and I'm going to unpack that in just a minute. So, and that looks at what people can do for themselves. Okay. It also looks at what kind of medical needs are they going to have. Do they still need to receive an IV? Do they still need to have a nurse come in or whatever, or a CNA, somebody to assist them? And then we look also as who can provide that care. If it is not highly medical, is it something where it's just helping somebody get from a bed to a commode, then it might be a family member or a friend. It could also be home health, and Beebe has a home health care unit that will go out and assist people if they need assistance with those activities of daily living. Now, with all of these, there are financial constraints. If you have not purchased a long-term care policy, many long-term care policies do cover this type of care, including in the home. A lot of them measure that on activities of daily living. There can be other triggers for that, but there is a cost that's going to happen. This isn't an automatic coverage.
No. And unfortunately, this does end up being a big consideration for a lot of our patients who might say that they want to stay in their home, but unfortunately, they can't care for themselves. So maybe they need assistance with those activities of daily living that Chaplain Paul's going to talk about. And it sometimes comes down to a financial discussion of, do you have the long-term care policy, or do you have funds that you've saved over the years to prepare for this, that you could pay for private caregivers. And unfortunately, for some people, that's just not an option. And then we have to look at some of these other long-term living situations.
And any hospital that as you've been in, or a family member has been in, we have something called discharge planners, our case managers. And they actually walk through they do a checklist of what can be done, what can't be done, and they assist you. So we don't just let you make your own decision on this. We evaluate you medically and financially and all of that before we actually release somebody.
And that's probably something we should have said at the very beginning, is that we're going to go through all of these different possibilities. And it's really just for learning, for getting a sense of what's out there. But in the individual scenario, don't feel like you're going to have to remember these names and pick things. There will be doctors and nurses and chaplains and case managers who will be helping you figure out what's an option for you.
So, but this is good. You're going to have this information at your fingertips, and you can always, this is going to help in any discussion you have for a family.
Absolutely. And understanding what it really means.
So let's just take a look at activities of daily living. And there are 6 of them. And they're very easy to understand. This is what we look at with an individual. Are they able to actually feed themselves? Can they pick up a fork or spoon and lift it to their mouth and receive nutrition that way? There is also bathing. Now that's not just cleaning the body, but it's all personal hygiene tasks. And that includes oral care, hair care, personal grooming, all the things that we do for ourselves to keep ourselves healthy, actually.
So things like brushing your teeth, brushing and washing your hair, all that kind of stuff.
Dressing. This is not only putting clothing on, but it's the ability to select the correct piece of clothing. People with dementia very often get confused about this. My mother, she lived in an assisted living, and she had great clothes. She loved wearing clothes up until that time. And for her, she could not understand about the clothes anymore, so she gave them away. Any of the workers that would come in, she'd say, well, I don't need this. I don't know what it is, so you may have it. So just, it's not only putting it on, it's understanding what it is.
I think another great example there is a patient I had who would put his clothes on himself, but for example, would put on dress pants and put them on backwards with the zipper and the button in the back. So there's a complexity of knowing how to do some of these tasks of taking care of yourself.
With regards to mobility, that's getting in and out of a bed or a chair, moving from place to place without assistance. Part of that is, I know that a lot of people will say at home, when we become frail, they have one of these lift chairs. That's great. And that actually helps that person get up. They're going to look at what is your mobility. Can you do it on your own? Can you move yourself?
With whatever level of assistance that might be, whether it's a walker, a wheelchair, etc.
Maintaining continence, and that's the ability to control bladder and bowel functions. That is looked at as an ADL as far as looking at people, can they control themselves in order to be able to get themselves to a bathroom and to actually moving to the toilet to get on and off the toilet. When an individual has lost that capacity, that means they've lost one of their activities of daily living and they need assistance.
And whether that assistance depends, whether that's a family member that is helping them to get to the toilet, whatever it may be.
Now, so if we can't get you home, you might want to consider an independent living facility. This is a very, and independent is the operative word in this, because this is generally, a lot of people will find that they say they want to move somewhere out of the big house. You know, my mother-in-law is in the family home, and she wants to move to some place where she could be and move around without all of the rooms and all of the cleaning and all of the pieces. So these are usually an apartment or perhaps a cottage. I think most of them, you recognize the moorings have these. They have cottages where a couple can live independently. The requirement to live in one of those or any of an independent living facility pieces, whether it's an apartment or a cottage itself, a standalone, is the ability to perform every single one of the activities of daily living.
So like Chaplain Paula said, independent is the key word, because someone who lives in their own independent living cottage, they need to be able to use the toilet, to shower, to dress themselves, all of those things.
All of the pieces that go together. And usually in places like this, they will provide the maintenance of the home and the property surrounding the home. There may be supportive services that can be hired out or within the staff people that they can bring in. The financial investment many times is, it's either, there are some very significant, you have to deplete everything and give them all of your assets in order to live. But many times they can move through graduating from a independent or moving in the opposite direction, independent, and then into assisted and then down.
Yeah, to some of the other options we're going to talk about as we go on.
So there is cost associated with these. We have them, again, the Freedom Center is another place. There are places throughout the area for this type of living arrangement.
And I will say this is a good option. We have a lot of patients who tell us they don't want to be mowing their lawn anymore. They don't want all that maintenance. But this is a good option.
Exactly. So the next piece is moving from, if I cannot perform all those ADLs independently, a person may benefit very well from an assisted living arrangement, which is what my mom moved into. She couldn't do everything for herself, so she did need assistance. It's in the past, it was called a retirement home. It was designed for originally for people with disabilities or for adults who cannot or choose not to live independently. A way to not have to care for anything and meeting the requirements of having a staff there. It is a group living environment. It typically caters to older adult population, which means there is a place in Maryland that my friend moved into, and it is completely independent. She has her own apartment, but it is all assisted. There is community events. There's a dining room to go to. There's somebody that comes in to clean her room. So there are pieces to go that, and that again takes you right to financial considerations. So these are generally costly.
Yes. And like you mentioned, someone may have bought into an independent living and then kind of go along the path to the assisted living section.
Correct.
Or someone could be going straight to assisted living and then they're still going to have to pay into it as well.
Exactly. So, and now if we've gone from independent to assisted, then we move back to the skilled nursing, which you brought up, but but to understand where this falls into.
So if you remember a skilled nursing facility we talked about before as somewhere that people sometimes go when they leave the hospital, if they might need more nursing care, or they might need an hour of therapy per day. Okay. So this is that same location. So it's for people that need sort of that extra level of care, even more so than the assisted living. And a lot of times people may come after they leave the hospital and they may continue to stay here.
So they wouldn't leave.
Exactly. So either if at the skilled nursing facility, maybe they don't get back to that baseline where they can live independently at home again. They might be now at a new baseline where they're going to need some ongoing nursing care. And so they may choose to stay in the skilled nursing facility as now their long-term home. So these are the places that you might choose to live, and or have to make the choice to live because of a loss of independence. And so there's different terms we use. Sometimes we call it residential care at the skilled nursing facility. We might call it custodial care at the skilled nursing facility. But this is going to be usually people that need more help with those ADLs. So it could be someone that does need help with toileting and bathing and eating, for example. Skilled nursing might be a place for them. As we've talked about each time, there are still financial considerations.
And unfortunately that exists. It's very real in our world today as far as these financial considerations. I mean, I know that you hear all about it, that you need $1 million in your bank account to retire safely. And I don't know a whole lot of people that can honestly say that even after years and years of working. So part of this may be insurance coverage and considerations of things like long-term care insurance, which is going to help at this point in time.
And sometimes long-term Medicaid can also come into play here. But like we said before, the case manager or discharge planner should be able to help advise on what is needed with insurance.
Correct. Now, we're going to move to the another topic, which I think people get confused about, and that is hospice care.
Mm-hmm.
I am going to read this. This was Dame Cicely Saunders. She was the founder of the first modern hospice in London.
Mm-hmm.
You matter because of who you are. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also, and this is the key phrase, to live until you die.
Mm-hmm.
Hospice care is not accelerating death.
Mm-hmm.
It is not trying to rush the process. It is saying we want you to live the best you can until the moment that God calls you home.
Exactly. I think a lot of people are afraid of the word hospice for a variety of reasons. Mm-hmm. But I think a lot of people believe that hospice, it just means death. Mm-hmm. It means you go there to die, or someone puts on a morphine drip and you die immediately. And that's really not what hospice is about at all. Hospice is about quality of life. Yep. It's about having the best time you can have for as long as you naturally have.
Correct. And it is a type of care that really does focus on quality, not only for the people, but also for the caregivers, the family members, mainly because when my mom went on hospice, it was not a good experience. And I think I mentioned that in the past. Mm-hmm. This was over a decade ago. And hospice has changed. Mm-hmm. It really has changed. And it is intended to provide assistance to that person to make their whatever time left that they have to be the best they can. It is really about compassionate care. If we cannot cure a specific disease, we want someone to live until they die. Uh-huh. And, as an example, perhaps someone, one of the patients has a stage 4 cancer that has advanced to brain mets.
Metastases. When cancer spreads to different parts of the body. So in this case, spreads to the brain.
Right. For that person, we can't fix that. We can't cure that by medical intervention any longer. And when we reach that point, hospice is a wonderful option. And for most cases, it is a financially paid for benefit. So it's not something that we have to talk about financial considerations in most cases.
Yes, that's true. It's a Medicare benefit. So it's free for anyone who has Medicare. And I think another example could be someone who has an end-stage heart failure or an end-stage COPD, which is a chronic lung disease. And so for people who might have one of those illnesses, a lot of times the final stages of that disease looks like spending a lot of time in the hospital.
Right.
Looks like coming back and forth to the intensive care unit, maybe coming on and off of the breathing machine. And for someone in that condition, going home with hospice can be wonderful. They can live longer at home with hospice.
Well, we have statistics about that. We actually have statistics that show us that people that sign up for hospice literally live longer than had they not accepted this type of care.
Yes. Yeah.
Because we're not trying, the hospice agencies are not trying to hasten it. They're trying to make it better.
Exactly. Yeah. And sometimes the aggressive care that we provide at the end of life, it doesn't actually help. Sometimes with all that extra poking and prodding, sometimes we cause more complications and people pass away faster. But for someone, for example, with an end-stage heart failure, they could go home, they could still have their heart failure managed by the hospice team. That's part of what hospice does, is provide the medicines to help you be comfortable. And they could live out their best time at home instead of being back and forth to the hospital.
And I think people get confused, you've used the term, I've used the term, but like end-stage COPD, there are conditions that a person can live with for an extended period of time. But many of these conditions eventually will be a life-ending condition.
Yes.
And not just cancer.
Right. Yes. So really quite a few conditions will eventually end up being an end-of-life condition. So heart failure is one, COPD, the chronic Lung disease is another. Renal failure on dialysis. So all of these are things that can be managed, you know, for some time, and then there may come a point where now that condition is leading to the end of life.
Okay. And it is a large team. There are chaplains, there are physicians, there are nurses, there's, you know, CNAs, which are the helpers. So it's a multidisciplinary team that works together and helps that person have their final days with dignity. And I think that's a really important word and something we think about all the time in the hospital. And
going all the way back to maybe our second week, when you talk about your values and writing down what's important to you at the end of life, dignity comes up again and again for our patients.
Absolutely.
Yeah. For a lot of people, that's important to them to feel that they are themselves and that they have some ability to have composure and feel dignified. And hospice really focuses on allowing that.
Correct. And what's interesting is that it can take place at home or in a facility. An example would be Delaware Hospice has a standalone facility up in Milford. And that facility will accept certain patients. There are criteria that you have to meet to be there. There's another place, it's up in Wilmington at St. Francis. No, it's at Christiana. It's Seasons Hospice, has a floor dedicated to taking care of patients who have selected hospice.
Yes.
And it also offers bereavement support. And we're going to talk a little bit about that at the end of today's session. But the hospice agencies will provide bereavement for family members. So it's really a really broad, wonderful service that you can get.
Yeah. And it really focuses on not only the patient and what's important to them, but the whole family.
Absolutely.
Because the process of going through end of life and grief, as we're going to talk about later, it really is, it's about, you know, your whole family, your friends, all the people you love in life.
Yeah, where you have been. I mean, it's that life that's touched so many.
And that legacy.
Absolutely.
Yeah. Okay. So I think we touched on this a bit already. But in general, hospice is used when one of those chronic diseases progresses to a point that we can no longer cure it, or perhaps we cannot control it anymore. So like we talked about, that could be an advanced cancer, it could be advanced heart failure, advanced kidney failure. In general, people are eligible for hospice when they have about 6 months or less to live. And that's if the illness runs its usual course. That being said, it is flexible, and there are a lot of people who live a lot longer than 6 months on hospice. And in fact, I also never want people to be afraid that if they make this decision, they're stuck. You can change your mind anytime. Sometimes people graduate from hospice.
Correct. That for whatever reason, their illness has become dormant or regressed.
Or they're just doing so well because we stopped doing aggressive things to them sometimes. Yeah. So sometimes people do graduate off hospice if they do very well. And sometimes people choose to revoke hospice, and that's okay. It's always up to what you want.
And part of that is also, it's a personality driven, because you may meet, say somebody's in the hospital, we may have one of the representatives come in to talk to the family and talk to the patient. And that person may be just the greatest person, and you feel very comfortable. But when you get home, the caregivers that come with that particular agency aren't to your liking. You can change. If you're not, there's nothing that's carved in stone.
Exactly, right. You could switch to a different hospice agency. You can rethink about your goals and your values.
Right.
Yeah. So
big star on the top line here. Right?
Big star. Yeah. So in the last slide, we mentioned that hospice is typically for someone who has about 6 months or so to live. Unfortunately, in real life practice, most people sign on much later than that. And unfortunately, a lot of people who use hospice don't get that benefit of all of that good quality time at home.
Correct.
Not because they're dying quickly because they're on hospice, but because they sign on so late in their illness.
And boy, we find that all the time. And I consult with so many family members who have had a family member who signed up and the patient died, you know, 48 hours later. That does not get the benefit.
Right.
And when it's a free service, in most cases are very, very low cost, I think it's people's fear that they're afraid if they sign up for hospice, we're just going to sign them off and say, we're not going to bother with you anymore.
But that's really not what it is.
Not at all.
So they have studies on this too, and almost half of people end up using hospice for 14 days or less, which is really a shame. Yeah, so they only wind up getting 2 weeks or less of these services. And honestly, the patients we see that sign on much earlier, they can have months and months of quality time at home.
And they do have quality. They do. I mean, it was an amazing thing for me coming on with the hospital system, you know, as a healthcare provider, to watch the people that sign on at the right time. They can live beyond the 6 months, and they're generally, they can see their family, they're with people, and they feel better. And because they feel better, they do better.
Yeah, right. And we can do more sometimes. Yeah. Right. Yeah. So as we said before, sometimes people think it means giving up, and it really doesn't. It's not stopping care. It is changing the type of care that you're getting, and care that's focused on your quality of life.
Okay. And I think that's important, because it doesn't mean that there's no hope.
Exactly.
Hope still exists. You know, we're pretty honest in the hospital when we have run out of hope, and we have to say that things are not playing out the way we had hoped. We have to be very honest, but this is not it. Hospice is not it.
And hope, I think hope can be framed a lot of different ways. I think hope is for enjoying the time that you have. Hope might be to spend time with your family or your loved ones. There's always something to hope for.
Indeed. And it may be at home, just to be able to sit in your living room looking at your garden, whatever it is. I mean, hope manifests itself differently. And again, we here in this population of Christians, we know that there is something to hope for that's beyond what we're dealing with here anyway. Oh, yay. So now we get to highlight Dr. Matthews as our palliative care physician, because this is so important, and I want to shine a spotlight on this. Palliative care, what Dr. Matthews is a specialist in, it is not hospice care. If somebody starts talking palliative care to you, a friend, a family, you have to know it is not. We are not even talking about hospice care. You can be, if you are in hospice care with the big umbrella, you're automatically under a palliative umbrella. But you can do a lot of other things under the palliative umbrella that does not include hospice.
Absolutely. And I would encourage you to not be afraid of the word palliative care. So palliative care, it's really a philosophy of care. It is helping to relieve pain and suffering, spiritual distress, helping to address people's emotional and social needs. It's really whole person medicine is what it is.
Which is why you got into this field.
Exactly. Yep. This is what spoke to me as I was going through my training and feeling like I was missing the whole person and only treating little bits of who that was. So palliative medicine, it focuses on the patient and what's important to them and their goals. It focuses on helping them feel well so they can function in the ways they want to. It focuses on their family or their loved ones, and also about helping them make choices that line up with what's important to them.
Correct. And most hospitals now, as we've been moving forward in time, have some palliative care knowledge. They may not have a staff as large as ours. I think I mentioned to you that not only do we have Dr. Matthews, but we also have Dr. Katie Johnson. We have a nurse practitioner, Karen Quay. You have Chaplain Keith and Chaplain Paula that are on that palliative care team. And we also have a patient advocate within the hospital system. At Beebe, that is Jody Barrulo. She's a member here at St. Peter's, and she's on our palliative care team also. So we have a broad group, and we're very proud of that because we're making a difference to these patients.
Yeah. And it's definitely a growing field. You may not have heard of it before, and that's because it is newer. But I will say across the nation, more and more hospitals are getting programs. Christiana has a very large palliative care program.
Yeah.
And I believe Bay Health has a smaller palliative care program. Any other hospitals we should highlight?
I'm not sure about Tidewater.
I'm not sure.
Yeah. But you can always, regardless of where you are, if there is a need, you can always ask for a palliative care consult. Is this appropriate for me at this point in time? If you've been suffering from a chronic illness, whether it's kidney disease, cancer, diabetes, any of these things would really qualify and find very good value in having palliative care get involved.
Absolutely. And palliative care is in the hospital with doctors like me. It's also in the clinic with doctors like Dr. Johnson.
Dr. Johnson. So we got you should have said that. There's a palliative care. We have a palliative care clinic.
Yes.
It's located down
at the
Continence Cancer Center. Okay.
And then Dr. Johnson does home visits too.
Yeah.
So lots of different ways to get palliative care. Like Chaplain Paula was saying, you can get palliative care at any stage of an illness. Yeah. So hospice is something that's for the final chapter. Palliative care is at any chapter of your serious illness. You can get it at the same time as aggressive care. You can get it at the same time as chemotherapy or advanced specialty care. You can get it at the same time as being in the intensive care unit on a ventilator. We're any stage of an illness.
Right. And we are involved.
Yes.
Quite a bit.
Yes, we are. So this image
is fabulous.
So it really just illustrates what we were just talking about. So the bottom scale is time. So on the left is kind of the beginning of an illness, and all the way on the right is end of life. And the vertical scale is the focus of care. So as you can see, palliative care is going along at the exact same time as curative care. That's like we were saying, you can get palliative care and chemo, you can get palliative care and advanced heart failure therapies. And as time goes on, your illness gets more serious, you might find more benefit from palliative care, as you're having more symptoms.
Absolutely.
And then when someone does come to that final chapter of their illness, where they do have about 6 months or so, then it may make sense for them to undergo hospice, at which time they're still getting that palliative care philosophy, but with specialized focused care for end of life.
Okay.
And then I think that last triangle is important too, because care doesn't stop at death. There's bereavement care, as we talked about with hospice, and Chaplain Paula is going to touch on that.
Yeah. And I did want to make mention in the handouts, and again, you can check with Father Jeff here. There is a list in there of all the hospice agencies that are within the state of Delaware. There are also, and whether I brought this up last time, there is also a list of all the funeral homes, not only in Sussex, but up in Kent County. And there's crematory services that are in here. So those are in your handouts. And as we start to talk about bereavement, there is a bereavement resource sheet in the handouts. These are excellent resources to be able to use. And I am going to stop here and do another, read something to you, because I think it's important as we talk about bereavement. It's so important to recognize that grief is normal. Our Psalms, have impassioned grief in them. There are many things that you can hear, and it is a normal human reaction, and there's no shame in it. And
a lot of our families, when we have family meetings together, this is something Chaplain Paula and I do a lot together. A lot of our family members will actually apologize for their tears and for their grief. They'll try to hide it, and I'm so sorry for crying. And we always encourage them that this is normal. This is showing your love for this person, and don't be ashamed.
and we really do mean that. And I say to many of my family members, I call it liquid love. Your tears are just a place where you have nowhere else to go with the love that you felt for this person. So there's no shame in it, and other people are feeling the same thing. in their lives. So this is from John O'Donohue. May you know that your soul, may you know in your soul that there is no need to be afraid. You're not going somewhere strange. You're going back to the home you never left. May you have a wonderful urgency to live your life to the full. May your going be sheltered and your welcome assured. May your soul smile in the embrace of your Anam Cara. And for us as Christians, we are going home. So this is something to keep in mind, that bereavement is normal and feeling bad is okay, but we're going back to where we started. So there's something to look towards.
That's beautiful.
This is from Mary Oliver, and I love this poem as a thought. When death comes like a hungry bear in autumn, I want to step through the door full of curiosity, wondering, what will it be like, that cottage of darkness? When it's over, I want to say, all my life, I was a bride married to amazement. When it's over, I don't want to wonder if I made of my life something particular and real. I don't want to end up simply having visited this world. And this goes back again to values and living life, quality life, to recognizing that every day is definitely a gift, and to really embrace that. And illness is part of life, and age is part of life, and death is part of life. And if we look at it with more of our hearts and our souls and our spirits, it's going to come through. We're going to face it better, which is why we are doing these sessions, to try and talk about it, to take the fear out of it, to talk about what it actually looks like. And of course, for us, we end with the words of our Book of Common Prayer, which you already know this. I am the resurrection and I am the life, says the Lord. Whoever has faith in me shall have life, even though he die. And everyone who has life and is committed himself to me in faith shall not die forever. And I've been saying it since week one, we're resurrection people. There is something more for us in our faith. And the reason we've trying to do this roadshow is to get people to recognize that life, death, everything comes together. It is all, the circle of life, from the movie, Lion King, but it is the circle of life. And some of it is taking the fear away. So we want you to look at that financially and things like that. The attorney will talk next week. If you have questions or comments, we actually did quite well on our time today, which is yes. So if you have any questions or comments that you want to raise to ask, we're happy to answer them. If you think that there is a need with any of women's groups, as now that we're finally opening up again, if you have women's groups or men's groups or any kind of organization that you feel would benefit from these type of classes, we are happy to talk to them. Please go ahead and refer. You can always let Father Jeff know. You can reach either one of us at the hospital, and we're happy to go back and explain to them, and we will adapt, these sessions. We've adapted these sessions to meet the Episcopal need right now, and if it's a secular group, we're happy to have that also.
And we just want to thank you all for participating in this. Like we said at the very beginning, these can be scary topics.
Indeed.
And we are so glad that people are interested and are here learning and doing, sometimes the tough work of opening up and saying, this is scary to me, but I'm going to learn more and I'm going to get more comfortable.
Especially when you've got family members that might have that disagreement. We talked about that earlier. People that have different opinions than you do as far as your life. And if these sessions, I know that Father Jeff has these left on the website. So if you've missed something and you want to go back and review something, please do. And again, we're not going away. We're right down the street. So
and I would encourage, if you went through all the sessions or if you're going back, Session 2 to do the worksheets about your values.
Absolutely.
And what's important to you. And then session 3, you have the conversation. Is that session 3?
Session 2 is conversation.
Oh, right. All right. Session 2.
Session 3.
There we go. All right. Well, session 2, get your values and have the conversation. And then once you're done with this, we really highly encourage you to take a look at the advance directive and write down some of your wishes, because this will be a tangible way to take everything you've learned and help protect what's important to you, and protect your wishes moving forward.
And bring that to Beebe and have it on file.
Yes. And
thank you, Father Jeff.
As Father Jeff says, please do bring it to Beebe and have it on file.
Yeah, because we will be asking for that. And I think we asked, don't we ask everybody?
We ask everyone.
Yeah. And if you don't have it, you can get one while you're there or your family member is there.
Yeah.
So don't hesitate to ask, because this, if you have this in the drawer, I know I have Tom and I filled ours out and we have it in a drawer and it's marked advanced directive. So we know where it is if it has to be used.
Yep. Mine are ready too. It's never too soon.
It's never too soon, as we said earlier.
Yeah. Anything popping up in the chat?
Okay.
Don't see anybody raising their hands.
Okay. All right.
So,
well, thank you all. We really appreciate it. Thank you to Father Jeff being willing to bring us in and offer this session. Again, don't hesitate. We're at the hospital most every day, and we're happy to meet you. Come in and say hi to us at least.
We had fun. We hope you had fun.
Yeah, I know it's an odd topic for us to enjoy, but we feel like we're making a difference.
Absolutely.
Okay.
All right.
Thank you.
Take care.